It is 5 o'clock, so we probably should start. Welcome all to this webinar of our ERN GUARD-Heart. The topic of today is complex cases in CPVT, which we probably all have. We have selected two to discuss for today, and the two will be presented by Auke Bergman, who is from the Amsterdam University Medical Center, and the second one by Dr. Georgia Bugada from Barcelona Hospital San Diego. If there is any question, please use the chat or raise your hand, and we will interrupt. We can interrupt the speaker, but you can also keep your questions until the end of the presentations. So, Auke, welcome. Please present your case.
Thank you. Let me share my screen. So thank you for the opportunity to present a case to this webinar. I'm a PhD student at Amsterdam University Medical Center, and I work on various heritable arrhythmia syndromes, and yeah, CPVT is one of them. By the way, if there's any questions, then yes, please, you can interrupt me in the middle because I don't think I can see them while I'm presenting. So the patient case I will present is a patient with CPVT where the decisions around management were difficult. I will give her a short little bit of background about CPVT, which is a heritable arrhythmia syndrome, which causes ventricular arrhythmias during exercise, emotions, and other stressful situations. The majority of cases are caused by genetic variants in RYR2, but no matter the specific genetic variant, the mechanism is calcium mistakes in calcium regulation in cardiomyocytes, which cause delayed after depolarizations and ventricular arrhythmia. So patients have a structurally normal heart, normal ECG, and for making the clinical diagnosis, the exercise stress test is one of the most important tests for making the diagnosis and also for follow-up. A typical exercise test in a patient with CPVT would be normal at rest, and as heart rate increases, more and more premature ventricular beats start to show up. Eventually, there could be ventricular couplets, non-sustained VT, and sometimes, rarely even, a bidirectional VT, as in this example. Now, the case I will be presenting was a boy of 5 years old when he first presented to the cardiologist, and that the reason for presentation was that there was CPVT in the family on mother's side, where there was a familial R420W variant in the RYR2 gene, which is a well-known pathogenic variant. And he himself was tested at the age of 5. He was tested positive. And then soon after, he underwent the first exercise stress test. So at rest, it was normal. At least there were no ventricular arrhythmias. And at moderate exercise and at peak exercise, it was also normal. At least there were definitely no ventricular ectopic beats or ventricular arrhythmias. Now the question at this point is, should he receive any treatment? So we have a young asymptomatic patient with a confirmed pathogenic variant, but no phenotype and no symptoms. Should he receive a beta blocker or not? Should he be restricted from exercise? Well, in this case, it was decided not to give him any medication. And the most recent European guidelines on the topic of CPVT recommend their general recommendations. So they would recommend an exercise restriction, and the beta blocker should be considered is a class 2 indication in this case. But as I said, in our patient, it was decided not to give any medication because he is very young without a phenotype. And a minor argument could also be that the specific variant that he has is maybe not the most malignant, but most important is his young age. So he was lost to follow-up during the following 6 years. So when he was 12 years old, he was again evaluated. And then he told the clinician that he had been lightheaded once during exercise, but otherwise had been asymptomatic all this time. And another exercise test was done. Again, at rest, normal during moderate exercise, and even at peak exercise, there were no ventricular arrhythmias. So the same strategy without medication was continued. 3 years later, he was evaluated again when he was 15 years old. He was more active than ever without any issues. But this time, the exercise stress test showed a single premature ectopic beat. So then the question is this enough to start medication? Well, it was decided that he was now developing a phenotype, so a beta blocker was prescribed and metoprolol was chosen, 50 milligram. Now I want to briefly touch on the role of beta blockers in CPVT and the choice of beta blocker type. As I'm sure all of you know, beta blockers are the first-line therapy in CPVT and have long been recognized as such. When it comes to the decision on which beta blocker to choose, I want to highlight the study from 2 years ago by my colleague Peltenberg, who studied non-selective and beta-1 selective beta blockers, during which she found that beta-1 selective beta blockers are associated with an increased risk of arrhythmic events. And specifically looking at all the different types, nadolol provided the most protection against arrhythmic events. And to a lesser extent, propranolol. Propranolol was not statistically significantly better than other beta blockers, but it was close. And similarly, around the same time, there was also a study by Mazzanti and colleagues who also found that non-selective beta blockers are associated with a lower risk of adverse arrhythmic events. And there was no difference between propranolol and nadolol. So the metoprolol was prescribed, and that was all quite a long time ago. So it was before these studies were conducted. Then 1 year later, he was still asymptomatic, but he admitted that he did not take the beta blocker, mostly for fear of the side effects. And another exercise test was done, which was quite similar. This time he had 2 PVCs during the exercise stress test. One of them you can see here. And because he was non-compliant with this medication, it was decided to try a lower dose to see if he would, he would actually take his medication. Yet another year later, when he was 17 years old, he had still mostly not been taking his metoprolol except for the last week before his appointment. But this time the exercise stress test, his phenotype was getting more severe. And ostensibly he had been taking his beta blocker the last week, so this was on a low dose of a beta blocker. And even couplets you can see here on the exercise stress test. And the question is, what should we do now in this situation? So the metoprolol was doubled back to the 50 milligrams. Obviously, the importance of taking the medication was stressed, especially now that the exercise test was not okay. And the new test was planned within a month, which was a little bit better, but not much. And again, 50 milligrams is quite a low dose for someone who is basically an adult at this point. So it was still not under control. So flecainide was prescribed as an addition to the metoprolol. And I want to also briefly show two studies looking at flecainide in CPVT. First of all, there was a small randomized control trial, one of the only, maybe the only RCTs that have been done in CPVT, looking at flecainide versus placebo. So in this study, of a small number of patients were given, have beta blocker plus flecainide versus beta blocker plus a placebo. And their outcome of interest was the arrhythmia score, so the severity of the ventricular arrhythmias on the exercise stress test. And they did find a significant difference. So flecainide did seem to be more effective than the placebo. And this is our own recent study where we did a retrospective case control study of all patients receiving flecainide. The outcome we studied was arrhythmic events, so appropriate ICD, shock, syncope, sudden cardiac arrest, and sudden death. And we found that the risk of arrhythmic events after flecainide was added was lower than before flecainide was added. So what do the guidelines say about flecainide? Flecainide is a class 2A indication, so it should be considered in patients with CPVT, and they recommend to give flecainide after a beta blocker, plus the general recommendations are proven to be insufficient. So a patient still has ventricular arrhythmia on the exercise stress test, or they are still symptomatic. If you give flecainide, the daily dose should be usually between 2 or 3 milligrams per kilogram. Now, unfortunately, patient suffered a sudden cardiac arrest when he was around 18 years old during a boot camp, so during intense exercise. Fortunately, police and firemen were nearby, so they could resuscitate him with an AED that was also nearby. He was admitted to the ICU in targeted temperature management, and fortunately, he made a full neurological recovery. But that's obviously quite shocking. He admitted again to being to not having taken his medications, has never taken the flecainide and the metoprolol, at least for a month before the event. He had not been taking it either. It was decided to change the metoprolol to propranolol in a slightly more adequate dose of 80 milligrams. And the flecainide was slowly up titrated over a few days to 200 milligrams daily, which is also an adequate dose for someone his age. And because of the risk and his history of non-adherence, it was also decided to do a left cardiac sympathectomy. An ICD was not implanted. So, during his admission, another exercise test was done, which was normal, fortunately, all normal. This was already before the cardiac sympathetic denervation. And a little bit of, a few slides about the sympathetic denervation. Basically, it's a surgical procedure where the sympathetic innervation of the heart is transected. Potential side effects are mostly Horner syndrome. And the strongest evidence for the efficacy of this procedure in CPVT comes from a circulation paper in 2015, where a retrospective study where the authors looked at the number of major cardiac events before and after sympathectomy, and they found that the absolute number of events was reduced by 92%, which is obviously quite dramatic, but a quarter to 1/3 of the patients did have a recurrence after the procedure. So it is definitely not a perfect therapy. Should also keep in mind that it's usually given to the most severely affected patients, of course. So, but it's not perfect. In the guidelines, it is also recommended as a class 2A indication after beta blocker and flecainide have proven to be insufficient. And of course, the major advantage of this procedure is that non-compliance is not an issue because it is a permanent procedure. A possible downside is that you need surgical expertise to perform this. So if you are in an area where that is not available, then this also would not be an option. Now,
okay, I do have some slides on ICD treatment.
Yeah, I'm going to skip over my slides about the ICD. As I told you, he did not receive an ICD. And as my final slides, I just want to let you know how it went after the hospital admission. Basically, he had yearly follow-up after that, and his exercise tests were consistently normal. He was asymptomatic after this time. He did have some side effects from the sympathetic denervation, namely some elements of a Horner syndrome, but he remained asymptomatic. So,
okay. Yeah, was that, you wanted to say something more?
well, I just wanted to, as my final slides emphasize what I think are the key challenges in this case, which is to balance the risk of ventricular arrhythmia with the risk of side effects, and by extension, the risk of non-compliance. And I think it's, as was done in this case, it's important to discuss the importance of taking medication, but not only that, to discuss side effects and with the patient to make sure they actually take their medication, or maybe a change needs to be made. And I was going to say, in terms of the ICD, that deviation from the guidelines is sometimes wise. But yes, so in conclusion, beta blockers and especially nadolol, propranolol are the first-line therapy still in CPVT. Flecainide is a potential good addition to that. And if both of those are insufficient, then a sympathetic denervation can sometimes be a good option. That was what I wanted to tell you. Thank you.
Okay, thank you very much. Okay, is there anyone who'd like to comment on this case? Either through the chat or by raising your voice. We can also discuss the case later in the discussion. So if not, nothing in the chat, then the second case will be presented by Georgia. Please, Georgia, go ahead.
Hello, it's a pleasure being here. Thank you for all that you are connected, and of course for sharing this evening with us. So in fact, it's very nice that I'll present his case, because actually probably it's the same difficulties we find when we have this type of patients, that they grow and we grow with them. And in fact, it happens in every house. So probably the beginning, it's going to be very familiar to you. This is a 9-year-old male, and he presents with 3 episodes of syncope during clearly a discussion. His baseline ECG is normal. He has an echo performed, which is normal, and a 24-hour Holter, which is normal. When we try to find out more details on these syncopes, they are clearly that he gets very mad, and suddenly he kind of weakens and he falls on that. But he's known to be very delicate or very like nervous, and this is something that say that in the family it's typical that people, when they get angry, they faint. So really nobody takes a big care of that. But the problem is that his mother, that was diagnosed of epilepsy to the same because of the same with the same clinical situations, she presented with sudden death at age of 27, and autopsy was inconclusive by that time, which was a while ago. So of course, a normal faintings while discussion, maybe in other cases, would not be kind of followed, or at least not, we would not do much. But with this family history, it makes the big difference here. And this is the very first clear point, that family history is very important. I mean, dying at 27, it's not normal. And mostly with an inconclusive autopsy. It's true, it's a socially depressed family, and with certain drugs going around, but of course she died, and this is very different. So she was seen in another hospital, and she was transferred to our hospital for a deep study on her. So we put him, sorry, it's a him. We put him on the EP lab, and we did isoproterenol test, which was negative. We did even gave flecainide test, which was not necessary, but anyway, there was a doubt on an ECG. Anyway, it was negative. And we performed EP study saying, oh, maybe he has some tachycardias. There was no arrhythmia induction. There were no accessory pathway. There was no inducibility on arrhythmias by stimulating the ventricle, and we implanted a loop recorder. We performed a genetic test that came with a genetic variant in ryanodine, which was a pathogenic finding. So then we start saying, okay, this is going to be something. Okay, so anyway, he did well by that time, and 3 months after, he presented with some nice tracings on the loop recorder. We could see episodes of atrial flutter and atrial tachycardia. We could also see this bidirectional ventricular ectopy, and mixed with atrial arrhythmia. And also we could see some episodes of atrial fibrillation. So except for those short, non-sustained VT, bidirectional VT, or those ventricular beats, which were kind of in a small run, the rest was clearly atrial arrhythmias. And that's been our nightmare since then, because atrial arrhythmias are not the typical finding in patients with ryanodine. Of course, we now know that there are certain patients with a lot of arrhythmias, atrial arrhythmias with ryanodine, but we would be expecting some more ventricular arrhythmias, and we would be treating the patient as a CPVT, as the type of syncopes he was presenting were clearly with a discussion. There was the family history of the mom's sudden death at a very young age, and we had this small bidirectional non-sustained ventricular tachycardia. So of course, he had his second syncope, and we have a very nice tracing with that. When we see that there is a ventricular tachycardia, like polymorphic, then degenerates into this kind of, I would say, it looks like a torsade de pointes, and then finally with the BF, and finally it spontaneously stops with this long pause and restarts sinus rhythm. So actually, as I said before, this family was socially difficult, and actually their monitor was not connected, and they never told us about that syncope. And some time later, when they connect the monitor, we received that, and we were kind of in a shock, you know, saying, okay, is he alive? Because it's difficult to treat, but that's the real world, okay? So, okay, of course, he was started on propranolol, and in his hospital of origin, he had what they say it was a sympathectomy, but actually then by exploring, and that's very important, the surgical report, he was treated as what the type of approach we would use to treat a hyperhidrosis, like the sweating of the hands, that we just click on the certain point on the sympathetic system. It's different for what we need here, that it's an exeresis. We have to take out from T1 to T5 to make sure that we get rid of all sympathetic innervation of the heart. And that makes a big difference. And that's why these procedures of sympathetic, left cardiac sympathetic denervation should be performed in centers who are used to that. It's just not exactly the same as the treating for the sweating hands. It's a little bit different, and that can be a reason of why some of the left cardiac sympathetic denervations don't really work. It's because sometimes technically it's not exactly the same, okay? So it's true that once we make sure that our surgeon understands what we want, then everybody's happier, okay? But that's very important. So he was started with propranolol, and very early approach that, but actually it was, well, I mean, he was kind of doing okay for 2 years, just with that medication. And 2 years after, he had a new syncopal episode associated with atrial fibrillation and ventricular tachycardia. He got, by that moment, because of the atrial fibrillation, atrial flutter, he got a new EP study, and we could see some non-sustained ventricular tachycardia. We could see that he was very easily inducible and atrial flutter, so we did an ablation of the cavo-tricuspid isthmus. And also there was a very regular atrial tachycardia coming from the coronary sinus, so we did an ablation of that point. And also there was a Hessian rhythm that was competing with the normal rhythm, but we did not touch that because there was a high risk of AV block. So we said, okay, let's see with all that if we can just control the arrhythmia. We also perform, because the family was not very compliant with the treatment, we also perform a proper left cardiac sympathetic denervation, and we suggested to switch to propranolol plus flecainide. I think it's a lot, and we really see it's a lot, but I promise that they were very uncompliant, and with all the treatments and the recommendations we were giving, and we said, okay, we will do as much as we can that they don't need to take medication, because we were not really sure that they would give the child the medication. So we said, okay, we will ablate whatever we can and do the left cardiac sympathetic denervation, and really recommend to do the treatment. But at least there was a lot we could do. Okay, so not late after, he did not present with flutter anymore, with no atrial tachycardia anymore, but he started with atrial fibrillation. And we decided to say, okay, let's try to control that, because it was a very fast conducting atrial fibrillation, and it was, he would have rhythm of 240 easily. So his AV node was very well performing. So we did cryo for that. We say, okay, let's just be subtle and let's go with cryo. And of course we say, okay, because our idea is to implant an ICD, and if he has a lot of atrial fibrillation, which conducts very fast, he will have inappropriate shocks on fast conducting atrial fibrillation. So we said, okay, let's control that. So despite all of that treatment, then he started with the ventricular tachycardia. We were pretty sure he was not taking the medication, and that's another episode he had despite all that. This time, yes, with this ventricular tachycardia developing with ventricular fibrillation. Okay, so we say, okay, let's recheck everything. We say, okay, let's go, because we could find certain episodes with the loop recorder. We could see that he was still doing some episodes of atrial fibrillation. We did CARTO to recheck, and there was one permeable vein. So we just closed that gap with CARTO to make sure, let me just put the video, to make sure that everything was quiet, because the really the atrial fibrillation was super fast. I hope it does not. Okay. So we could get into a rhythm control with no arrhythmia now, with nadolol and flecainide, having this left cardiac sympathetic denervation and ablation of atrial flutter, atrial tachycardia, and atrial fibrillation. So actually the nightmare for this child has been the atrial tachycardia, was very fast conducting. So for us was, okay, is this the treatment really the appropriate treatment, nadolol plus flecainide, the one that will preserve us from atrial tachycardias, or should we add something in those cases? So, but then we have to have in mind that he has two other brothers. So we could have blood from mom, and we confirmed that mom was carrier, of course, for that ryanodine 2, and also was the grandmother who was presenting with many episodes of syncope and epilepsy while she was younger, but he stopped doing that while after. Fortunately, the two sisters and the brother were negative for the ryanodine, and we could not go further here up to see if there was from grandma, if there was something here we could treat. And there is a third brother not carrying the mutation. But this young brother had exactly the same atrial fibrillation, non-sustained ventricular tachycardia, despite the medication. So we just decided to go directly to CARTO to isolate that, and really we could have an absolute control of the arrhythmias, and with all that, but having an absolute control of the arrhythmias from the very beginning. So here, why I'm presenting this? Well, because there are certain cases that we have mainly an atrial involvement, and we have to think which is the most appropriate approach, because in these cases with syncopes, seeing BF, it's easy to say, okay, I need to implant an ICD. But if I'm implanting an ICD with atrial fibrillation, with such a fast conducting atrial fibrillation, which is, I'm telling you, asymptomatic completely for this child, I'm going to have a lot of inappropriate shocks. Inappropriate because there's going to be shocks on atrial fibrillation, which is asymptomatic. So we really need to have a good control of that. Otherwise, we will have a lot of shocks that then we know that with the ryanodine can turn into adrenergic shocks. So the other thing is that, okay, let's do an AV node ablation, forget about the atrium, stimulate the ventricle, and make sure we put an ICD there. But this is a very big thing for a 13-year-old boy just doing an ablation of the AV node. And what is most important here, and that could make us arrive here in this situation, is that the role of the loop recorder here, because all these episodes, except when he was fainting, the rest, he was asymptomatic. Even at 240 of heart rate in atrial fibrillation, he was asymptomatic, or he told it he was asymptomatic. He never complained of that. So this is very important to know what to do with these patients in order to have them very well controlled. So I would be more than happy to share your impressions on that, and which would be the ideal treatment, and if ablation has been a very good point for us to control that. And I think that even they were very young, both brothers, we needed to reach that point, but it's true that this is a big thing for them. Thank you.
Thank you, Georgia. Can I ask, were the atrial arrhythmias also exercise-induced?
No,
They
not
were
at
not.
all. No, actually, this is something that it was because we did exercise tests on them when he was younger, and we could not even see a single ventricular ectopy. And in certain cases, you know, they are hyperactive, and they are very uncontrolled children. You know, they skip school and things like that. So actually, you never know what they are doing, and often we get to know about all these episodes when once per month they connect the monitor, and then we receive everything, and it's like, I know, wow. So it's difficult to say, but he gets very mad when he comes to the hospital. Really, he gets very mad, and it's a good moment to check the adrenergic impulse, and he's not really doing those arrhythmias in those episodes of madness he has when he gets to the hospital. So I would say that it's very difficult to reproduce.
And one of the problems with flecainide is that flecainide potentially speeds up AV conduction. So if all the arrhythmias are during flecainide, you might have faster conduction at the AV node than otherwise. But you cannot do without flecainide. You have to phenotype a CPVT at the same time. Okay, any other question? If not, I will take the screen. I'm going to touch on both cases briefly, and at the end we may have time for some discussion. So this is already discussed. Catecholamine-induced polymorphic VT is an autosomal dominant disease, complaint during exercise, emotion, and may actually start often at young age, and the baseline EKG is normal. The ryanodine receptor is critical here. That is a protein in the SR membrane responsible for the release of calcium from the SR into the cytosol. And the genetics is explained here. It's a ryanodine receptor, which is the most important one. It's about 60%. The others are more rare. And the diagnosis is obviously based on exercise or emotion, adrenergically related arrhythmias. If we start at the left, the top here, if there are exercise-induced polymorphic ventricular arrhythmias, and at the same time you have arrhythmias at rest, you're probably not dealing with CPVT. You have to consider other electrical syndromes like MEPPC. If there are no arrhythmias at rest, then other EKG abnormalities have, of course, to be excluded. So long QT should be excluded. But if the QTC is long or abnormal U waves, Anderson-Tawil syndrome is a disorder to consider. If there are no arrhythmias at rest and no other EKG abnormalities, then structural heart disease needs to be excluded, because there are some diseases in the cardiomyopathy field that also combine with exercise-induced arrhythmias. And if that is excluded, then based on the age of symptom onset, in both cases today we were discussing children, so then you can safely conclude that the patient has CPVT. But if the patient is older, you also have to exclude ischemic heart disease which can also lead to exercise-induced arrhythmias. So the cases discussed today were the first case was a serious event on therapy, but it was all around non-adherence. And the second case was serious events despite maximal therapy. And the second case was also a lot of atrial arrhythmias. Let me first put some emphasis on the adherence in this condition. We recently published this in 2024, so earlier this year, also per Peltenborg. She did a survey, an international survey through internet. 200 CPVT patients from all over the world filled in an online survey. And it turned out that at least 15% of these patients are self-declared non-adherent. Probably a bit higher then, but the 15% admit that they are non-adherent. And that mainly relates to concern about medication, concern about flecainide monotherapy, and female sex were independently associated with non-adherence. So non-adherence is an issue in CPVT. ICD treatment could have been considered in our first case, but the problem is several folds. This is a paper from 2013 from Christina Miyake from Boston. She published a multi-center study, historical data on the efficacy of implantable cardioverter defibrillators in young patients with CPVT. And there were 24 cases in the pediatric age group. 12 had secondary prevention ICD, 6 based on cardiac arrest. And 14 of these 24 patients received 140 shocks. And I'll take you through this paper briefly. 10 patients received 75 appropriate shocks, all for ventricular fibrillation, and 43 were successful primary termination. 11 patients received 65 inappropriate shocks. If we start at the top here, the 140 total shocks, and we go to the left, which is the 75 appropriate shocks in 10 patients, then the breakdown in terms of the arrhythmia mechanism is 43, it was ventricular fibrillation, and all these were successfully terminated by the shock. 29 of these patients had polymorphic ventricular tachycardia, and here the VF shock, or the shock of the defibrillator, was not successful. And that is because the mechanism of this polymorphic ventricular tachycardia is delayed after depreciation, triggered activity, and that is a mechanism that is not sensitive to shock, to electrical shock. Spontaneous termination occurred in 13 and only well after the shock in 11. And the 3 patients with bidirectional VT also had non-successful termination of the shock. So depending on the arrhythmia, the ICD is effective. In VF it is, in the other CPVT-related arrhythmia, it is not. And the 65 inappropriate shocks, and that adds well to what Georgia learned us a minute ago. Many of them were related to atrial tachycardias. Some were related to ventricular tachycardias that had already spontaneously terminated before ICD discharge. There's always a percentage which is related to noise. The main problem of ICD therapy in patients with CPVT is that some of these discharges, and this study was 12 discharges in 5 patients, and that is almost 10% of the total shocks, resulted in a more malignant ventricular arrhythmia than the arrhythmia for which the shock was given. And 4 out of the 14 patients who received ICD therapy had electrical storms secondary to the ICD discharges. So ICD therapy is not without risk in these patients. And this is a case published by Michael Gollop and colleagues, where they actually demonstrated that an inappropriate shock based on atrial fibrillation, so So this patient had inappropriate shocks based on atrial fibrillation that resulted in an electrical storm and a sudden death of this patient, that despite therapy. And I think it's safe to say that this patient died because of the ICD and not because of the CPVT. So ICDs may be pro-rhythmic. ICD therapy may not be effective. Randomized data on ICD therapy lack and will not be easy to obtain. And I always say that you may actually wonder how many patients are out there that are not reported or just classified under failed ICD therapy. So we did this study from the International Long QT Registry in 2019. And Christian van der Werf was the first author here. It was based on the International CPVT Registry. Sami Visken wrote a nice editorial here, if you're interested. The reference is in the same European Heart Journal issue. And the basis of the study was 164 patients presenting with sudden cardiac arrest and diagnosed with CPVT. Some had to be excluded because essential information was missing, etc. 136 were included, and 79 had an ICD, and 57 had no ICD. And the two patient groups were comparable in all characteristics. And this is the final result after ICD implant at 0.0. So the cumulative probability of sudden death is actually a little higher in the ICD group than it is in the no ICD group. And please be reminded that all these patients had suffered from a cardiac arrest at the start. I think at either an ICD or when follow-up started. Now, if you include here appropriate ICD shocks, then it's of course it's unfair because only the ICD group in pink here can receive ICD shocks, and the no ICD group cannot receive an ICD shock. So this comparison may be considered unfair. But if you then assume that every appropriate ICD shock is associated with syncope, then you can add syncope in this equation. And that is what is done here. Then you still see that in the ICD group, the number of events is significantly higher than in the non-ICD group. That may relate to programming, so all these ICD shocks are probably not needed. But still, the issue is that in the ICD group, there are more events than in the non-ICD group, whereas both patients group are at high risk. The ICD therapy comes with a price. Inappropriate shocks in this generally young population is almost in 25%, and other device-related complications in almost 30%. Now, there is a second, more recent paper on ICD therapy, just published in Heart Rhythm, also a very large group of authors. And this is with data from patients are all pediatric patients here below age 19. They are symptomatic CPVT, but in this cohort, cardiac arrest victims are excluded. The phenotype has to be positive, so there should be symptoms, and there is an exercise test indicative of CPVT. And the patients were only selected if they had a ryanodine receptor positive variant, a pathogenic variant. In total, there were 235 patients from 2 registries, 73 had an ICD, and 162 had no ICD. Now, the data here this is the risk of first appropriate ICD shocks and years of follow-up since ICD implant. And this shows that in almost or in 40% of patients over time, there is an appropriate ICD shock. Then it is, of course, important to look at who these patients are. And this is what these patients are, 73 patients. Indeed, there were 31 patients who had appropriate shocks. But out of these 31 patients, 50% were only on propranolol and nadolol, and the others were on the other, if I may say, inferior beta blockers. And from the patients where the information was available, then 50% turned out to be non-compliant, like our first case. And in 25% of the remaining, there was suboptimal treatment. So only 25% of this group had appropriate treatment. But still, flecainide was only used in 61% and left cardiac appendectomy in only 31%. Also in this study, there was a significant number of inappropriate shocks, and 25%, and other complications in the same order as in the previous study, 30%. So I think we have to conclude that ICD therapy in CPVT patients may indeed be life-saving. So if you are really dealing with a high-risk patient, you should not avoid ICD therapy for the reasons that I have mentioned. You have to implant an ICD in the really very high-risk patients. But you should realize and discuss with the patient and the family that it has a very high yield in inappropriate shocks, it has a very high yield in ineffective shocks, it has a high yield of other complications, and it may be proarrhythmic, and that can probably cause death. And that should all be discussed with the patient or the family in case you are dealing with a child. I think the vast majority of patients are well controlled with beta blocker and flecainide, but we have to be sure that they are compliant. Not all are compliant. I think left stylectomy is used not too often, should be used more and should be done in an appropriate way, as Georgia emphasized. And I think in general, an ICD should be avoided, but sometimes you cannot do without an ICD. Then the second case, Georgia already has mentioned almost all that I'm going to say. So this case had a significant atrial arrhythmia burden. I don't think we really understand why that is, but the ryanodine receptor is obviously also in the atrium. But why there are more atrial arrhythmias in some patients than in others is simply not known. This was all done, lifestyle advices, beta blocker, flecainide, stylectomy, and ICD. That is all part of the general treatment strategy in CPVT. And then the atrial arrhythmia burden is higher than you may think. These are 4 studies from different continents, from Paris, from Japan, from Canada, from the pediatric CPVT registry, and from Australia. And as you can see, atrial flutter and atrial fibrillation is present in about 20% of the patients with CPVT, and that is already in young patients. Actually, quite a few here are in the pediatric age group. This study was limited to adult patients. Then additional therapy could be considered bilateral sympathectomy. I think the advantage of ablating the right, interrupting the right stellate, is that you reduce sinus rate, and you also reduce sinus rate a little bit with exercise. If you're dealing with ventricular arrhythmias, there are some case reports. I will show you one where ventricular exosystoles are ablated. There are, of course, multiform, but many of them have the same morphology, so you could ablate the predominant ventricular exosystole. The use of ivabradine, I will briefly show you a case report, and as Georgia already mentioned, ablation of atrial flutter and atrial fibrillation is the way to go in cases where atrial arrhythmias are predominant. This is the case on ivabradine. What ivabradine does is reducing heart rate and also reducing heart rate with exercise. This was in an 18-year-old with an in-frame exon 3 deletion, so that's not the typical CPVT probably. Yet he was highly symptomatic. And here at baseline, what you see here is the heart rate during exercise. And the arrhythmias are with these symbols, so ventricular exosystoles with the blue star, non-sustained VT with this purple star, and ventricular tachycardia with the arrow, the green arrow. At baseline, all arrhythmias were there, and heart rate goes up rather fast. At therapy with flecainide and nadolol and post-stylectomy, so the maximum therapy, he still had ventricular exosystoles and he still had the ectopy, but at if you add ivabradine here, then heart rate doesn't go up as high. You see here it goes up to 140, it goes up to 110, so it's already significantly reduced by the therapy. But here it goes up to 80, and then the only arrhythmia that is seen is the ventricular extrasystole. So ivabradine may be something to consider in resistant patients, and what you do is you reduce heart rate increase during exercise. Catheter ablation for ventricular ectopy has been done by this Japanese group, and what they target is the extrasystole 1, and as I mentioned, it's polymorphic, but the first one is apparently predominant. That is the one that they targeted, and they have done so successfully. Interestingly, many of these extrasystoles seem to come from the Purkinje system, from the conduction system, so they can easily be found. And with the preceding Purkinje potential, you can target accurately where the ectopy comes from. And catheter ablation for drug refractory atrial tachycardias has also been reported from Japan, 2019, of a similar patient as Georgia discussed, but she was older, 43-year-old, persistent atrial fibrillation, atrial tachycardia. PVI was performed and multiple atrial foci induced by isoproternal were targeted, and she had a symptom-free 1-year follow-up. That's it for now, and I hope we can have some brief discussion now on the two cases. A few minutes left. Is anybody want to add something? You have similar experience? Georgia, have you experience with ivabradine?
Yeah, we use ivabradine very often for atrial tachycardias, even in newborns, and it works really well. Actually, it was the next, but when everything happened, ivabradine was not that extensively used, and actually it was off-label in pediatrics. So now I would probably offer ivabradine, but there is also a structural. I mean, a flutter is a flutter, and you need to ablate.
Yeah, that's clear.
I think that maybe for I would say that if atrial fibrillation could be controlled with ivabradine, I don't know. The problem is that once again, this is a general channelopathy, and it's not a matter of ventricular. And I think what it's most important is that there are certain arrhythmias that can end up being very fast on the ventricles, but it's not really ventricular tachycardia in the origin. And we really need to make sure that we have clear in our minds that atrial tachycardias exist in those patients, are very, very, we can see them very often. They are frequent, and some of them may be asymptomatic, and this could really mess up when we implant an ICD. And that's the clear idea that I think it's important to have in mind. And of course, ivabradine is a good new tool, and for us it's new, at least in the pediatric world. But it can be used really safely with a wide range of doses. So it's clear something to be used.
Okay, thank you. Any more comments? There are other experts online. Annika, Fabrice, anything to add? If not, then I think we are at the clock of the hour, 6 o'clock. So I'll wish you then a very pleasant evening. Thank you for attending. Thank you, Georgia. Thank you, Auke. Thank you all. Have a nice evening.
Thank you
very much.
Bye-bye.
Thank you,
Bye-bye.
Arthur.